so that you don't disturb the sleep. And when you talk softly, they actually want to hear what you say. I won't do that.
Those are light. And
Okay.
backwards and forwards.
Thank you. I'm only understanding today why I should be part of Succeed. Thank you. Thank you. It has helped us a lot in the work that we do. But now I think it's also important for Succeed. I do feel a bit, but just a little bit, lonely. Now, may not be there. But you guys know the soccer field thing that I always talk about. That you can only score a goal if you are actually near the goal. Mostly. I mean, there are guys like Messi that can do anything. But for normal people, you can only score a goal when you're near them. In our definition, the penalty area of the goal is that area between the clinic and the home. And the goal in health is what happens in people's homes. I'm looking at the ideal clinic champion. The point is, what happens in the clinic may be important, but what happens at home is actually what counts. And sometimes I say to students that a home visit is like a laparotomy in a patient with acute abdomen. It's only when you get in there that you see what's going on. So I feel a bit alone in front of this informal house. I'm trying to knock here and I look around and all my colleagues are at the clinic. And they're busy with marvelous plans at the clinic. But, okay, so I've dealt with that now. Is it okay? The point that I'm saying is you have taught the student incompletely if the student doesn't know, first of all, how to do a home visit, but more importantly, how to support and work with a wobble. Because that doesn't come naturally. You don't learn that thing at the clinic. My one chief years ago said to me, "Man, just make a simulation of a home visit in the skills lab." I said, no, we won't try that one. So the point that I want to challenge all of you, including myself, and it's not a simple challenge. The work of Succeed is not complete if you haven't included wobbles and homes. And I have to say to you as a technical person and a team member, because one day somebody will ask me, "You've been part of Succeed, huh? Have you? What did you hear there? Oh, and what did you do? You sat there and you ate lunch. You didn't talk." It's not in my nature to do that. So the point that I want to say to Succeed management, the conceptualization that I pick up from the DHS to QI to the sites as a major gap, and that is from the clinic to the home and back. And what I'm going to show you here is an attempt to bridge that. So I thought I'll talk to linkage to care. That's 1990. Just a story about first year students and then final year students doing the projects. The first vision we had about ITA and ITA is used by community health workers, is that students will use it as community health workers when they do home visits. We had to change that a lot because students are not community health workers and they don't work exactly like them. That's why we had to change it. But this is just an experience in 2017 when we sent students to 60 Wobots to review the work of the Wobots. They actually did a formal review. And on this particular day, 150 students went out, but TB was not on their agenda. But somehow on the app there's a triage, and this is what the lecturers saw on the website. That students were identifying patients with unresolved TB from about Broncos straight to Centurion to Hammanskraal. And he actually saw that on the app while the students were working there. And because we had the names and addresses of those places, we could make sure that it was followed up by the community health workers and resolved. The other thing we did was the QI projects for students in Tshwane, final year students. Then they did the whole lot. We said must work on TB management because it's a problem, and they presented that in the district management, and people were there from the municipality and HUST and whatever, like we are here now. And those were 3 students from a clinic and the family physician. And these were just the projects they did. Some were related to going to the community, contact tracing, the follow-up of people at home, the screening of people at home. There's some work that's been done now that you can do, instead of sputum, do a mouth swab or a mask. To follow the patients from the hospital to the clinic using another electronic system, and to follow up the patients from Steve Biko from the tertiary hospital. That is also a chaotic thing. And they came up with recommendations, TB contact tracing at home by community health worker, improve linkage to care using ITA Health, and do the sputum collection at home, etc. So what we did then was we actually had to adapt the app quite significantly so that it can work for linkage to care. Because when we initially developed the app, it was purely for community health workers to work and get guidance, etc. Because we were told, don't worry about the clinic, we'll put the systems in the clinic and we'll link in the clouds. But obviously that didn't happen. So now we've changed ITA so that we can follow the patient from the clinic to home and back. And that is what Sanele Ngobo is working on with a specific team at the moment to try and sort it out. And by the way, they say we should talk about connecting to care and not linkage, because the connecting is the ongoing thing. You don't just link it once. And this is ITA, you guys know about that. I'm not going to go there. This is the point. Linkage to care is to initiate HIV-related medical, psychological and social services for newly diagnosed HIV persons. And the literature has shown that an improvement in adherence and default rate if people are visited at home by community health workers. But how? So what we now have is to have a linkage officer at the clinic who follow it on the website and do the referrals to the clinic, to the community health workers. And this is what he sent to me last night. These are visit notes from which the team leader can see. That was for the 8. This is in Kakana Stad. And the team leader sends a message that say, report back on the response on HIV referral. And there you get an answer. This person was not available, will come back on Monday. The client will be seen on Tuesday, that date. This client has moved, but the person will come. The client called now and he said he's in the clinic. Okay, we will monitor her. Please don't forget to complete the household registration, etc. So we can now do this job electronically. And you know the difficulty of giving people a list of names to go and hunt. We can now do that electronically. So what he said is, in this clinic, they have 104 patients lost to follow-up. And of that, 28 files were given to the linkage officer. They were registered on ITA and allocated, and by this time 15 had already been traced. So the point that I'm making, and we're also saying this to CDC and USAID, the big push for the 90-90-90 can only be done responsibly if it's at the same time the ward-based outreach teams are put in place and part of the intervention. I am personally very concerned about the number of people that will be put on treatment unsuccessfully in the next few years with this approach of testing and treating. It's fine if it works, but if you can link that to a community health worker, and now that the community health workers are doing tests at home, that is the ideal. For the community health worker to actually do the test, find it to be positive, and then negotiate with the patient to go for treatment, and then the loop is closed already. And that is happening at some places, and if you do that on an electronic system, distances are not the issue, and you can monitor what you do, what is happening. I said to a district manager the other day to just, many times, people confuse ITA or similar systems with M&E. Now it could be M&E, but this is similar to an anesthetic monitor in theater. You would not run a theater without a monitor responsibly. I know you sometimes have to, but you don't want to, because the person who's giving the anesthetic can in real time monitor what's going on and take decisions on what should be done. Now, this is what the data system is doing in terms of HIV and TB and other things. The community health worker is doing the walking and visiting, and you can see what the results are. So I'm saying that if you are not prepared to do anesthetics without a monitor, you should also not be prepared to do COPC without mobile technology. Doing COPC is more complex than doing an anesthetic. I've done both. And more people die because of bad primary care than people die from bad anesthetics. So, after our discussion today and what we think about, I want to propose that each learning site identify at least one robot, and we equip those community health workers with cell phones and run the system as it should be run, even if it's just for the sake of the students learning something which they will be able to do in future. Those are just the statistics of those things. Okay, so the way forward, we're going to do large-scale linkage to care. What happened because of ITA student, we are now able, we've changed the app so that we can work much more flexibly with the community health workers. So we're going to do linkage to care on a large scale. The students will all use ITA Health when they do visits to homes, clinics, old age homes, etc. WITS will have 375 students that go to 10 community visits in June and September. Thank you.
Thank you very much, Annie. I really like that challenge. Just one, what did you say? Identify one robot in each of these learning centers